In this lesson, I will discuss about syncope. Syncope is defined as a sudden, transient loss of consciousness with inability to maintain postural tone. When we see cause of syncope, the cause of syncope is classified as neuroendocrine, orthostatic, cardiac arrhythmia, or structural cardiac anomalies. But the most common cause of syncope is neuroendocrine, mainly vasovagal syncope. Around 10% of syncope can be unexplained. The most common cause of syncope is, as I have said, neurocardiogenic syncope or vasovagal syncope, sometimes called fainting. Vasovagal syncope is classically associated with a prodrome that includes diaphoresis, warmth, pallor, or feeling lightheaded. Vasovagal syncope is often triggered by specific event or situations such as pain, medical procedures, or emotional distress. This type of syncope is characterized by hypotension and bradycardia. Approximately 30 to 50% of children will have fainting episodes before 8 years of age. Most patients with vasovagal syncope episodes will have prodromal features followed by loss of motor tone. Once in a horizontal position, consciousness returns rapidly in 1 to 2 minutes. Vasovagal syncope is very common in adolescents and has an excellent prognosis. But other cause of syncope is more dangerous. The most important goal in the evaluation of new patients with syncope is to diagnose life-threatening cause of syncope so that these cases can be managed. Many patients presenting with sudden cardiac arrest caused by a condition such as long QT syndrome will have previously experienced an episode of syncope. So the presentation with syncope is an important opportunity to prevent sudden death. The most important tool in evaluation of syncope is a carefully taken history. The characteristics of cardiac syncope differ significantly from the prodrome seen in neurocardiogenic syncope. Red flags for cardiac cause rather than simple fainting includes the occurrence during exercise, which suggests an arrhythmia or coronary obstruction, injury because of an episode of syncope, which shows there is no prodromal symptoms, occurrence of syncope while recumbent, and the sensation of racing heart before the event. A careful family history is essential in evaluation of syncope. Specifically, if there are first-degree relatives with inherited syndromes, such as hypertrophic cardiomyopathy and long QT syndrome, this should lead to more specific evaluation of the patient. Also, if relatives died suddenly at young age without a clear and convincing cause, inherited cardiac arrhythmia or cardiomyopathy should also be suspected. The physical examination may also offer clues. Patients with hypertrophic cardiomyopathy may have a prominent cardiac impulse or an ejection murmur, as well with patients with aortic stenosis. The patients with primary pulmonary hypertension will have a loud and a single heart sound and may also have ejection click and a murmur of pulmonary insufficiency. Scars from prior cardiac surgery and pacemaker implantation would be evident. All patients presenting with a first episode of syncope must have an ECG obtained looking primarily for QT interval prolongation, pre-excitation, ventricular hypertrophy, T-wave abnormality, and conduction abnormalities. Other tests that can be needed depending on the result of the initial evaluation might include echocardiography, exercise testing, cardiac MRI, or 24-hour Holter monitoring. Additional tests to look for, such as anemia, hypoglycemia, drugs of abuse, and other etiologies, will be determined by the history and the physical examination. When we came to the treatment, therapy for vasovagal syncope includes avoiding triggering event if possible, fluid and salt supplementation, and if needed, midodrine. Immediately after the event of vasovagal syncope, the patient should remain supine until symptoms abate to avoid recurrence. Treatment for cardiac cause of syncope will be determined by the diagnosis. If a reentrant tachycardia is found, a catheter ablation is indicated. If bradycardia from AV block, pacemaker may be warranted. Patients with syncope from medically refractory malignant arrhythmias may require an implantable cardioverter defibrillator, and patients with structural heart disease should be referred for surgery. This is a summary of syncope in pediatrics. Thank you for watching.